Hi, this is Dr. MRUDULA. Today I'm from Sri Lakshminarayan Institute of Medical Sciences, Pondicherry. Today we are going to discuss about carcinoma tongue. Before discussing about carcinoma tongue, we need to know about the anatomy of the oral cavity in the tongue. So we'll go get into the anatomy of the oral cavity. So the oral cavity extends posteriorly from the lips to the junction of hard and soft palates superiorly. Anterior tonsillar pillars are the lateral boundaries of the oral cavity. There is a line of sulcus terminalis and circumvallate papillae of the tongue inferiorly. And the oral cavity is divided into the lip, oral tongue, floor of the mouth, buccal mucosa, lower gingiva, retromolar trigon, hard palate, and upper gingiva. So this is a picture which shows the anatomy of the oral cavity. You can see this is the oral cavity from the lips to the anterior tonsillar pillars. This is the tongue. This is a hard palate, and this part is a soft palate. These are the lips, and this is gingivae, the gums, and this is a tongue. This is a lingual tonsil, oropharynx, epiglottis. So this gives a better picture. This shows the upper lip, the gingivae, and this is a hard palate with the midline palatine raphe, soft palate, anterior tonsillar pillars, the palatine tonsil, the tongue, the base of the, this is the inferior surface of the tongue and floor of the mouth, which shows the opening of submandibular gland, and these are the lower gingivae. This is a vestibule and inferior lip. Coming to retromolar trigon, it is a very important region in oral cancers. So it is defined as an anterior surface, the ascending ramus of mandible. So it is somewhere here, anterior surface of ascending ramus of mandible. It is usually triangle in shape. The base is upper or superior behind the third upper molar tooth, and apex is inferior behind the third lower molar tooth. And the mucosa is closely adherent to the ascending ramus of mandible. So this is a retromolar trigon roughly. So carcinoma in this region often invades ascending ramus of mandible and may spread upwards to involve the pterygomandibular space. A lip split and mandibulotomy are needed to gain access to this region. There is a referred otolgia occurs from innervation by trigeminal nerve, lesser palatine nerve, and glossopharyngeal nerve. Lymphatic drainage is usually through level 2 lymph nodes. So see, this is a classical region of or the retromolar region. It is behind this is a superior this is a base of the trigon. This is the apex of the trigon. So the base of the trigon is behind the third molar, upper third molar. And coming to the anatomy of the tongue is a muscular structure which is covered by non-keratinized squamous epithelium. Anterior 2/3 of the tongue is called an oral tongue. The posterior 1/3 of the tongue, which occupies the oral pharynx, is called the tongue base or lingual tonsil. There is a line of demarcation known as sulcus terminalis, which is a V-shaped groove behind the circumvallate papillae. And the dorsum of the tongue is covered by filiform, fungiform, and circumvallate papillae. There is a foramen of cecum at the apex of the sulcus terminalis, which is the site of origin of the thyroid gland, and on the ventral surface there is a frenulum linguale. So this is a anatomy of the tongue describing the circumvallate papillae, the palatine tonsils, the lingual tonsil, the folate papillae, filiform and fungiform papillae. Coming to the muscles of the tongue are divided into the intrinsic muscles and extrinsic muscles. Intrinsic muscles are superior longitudinal, inferior longitudinal, transverse, and vertical muscles. And extrinsic muscles are genioglossus, hyoglossus, styloglossus, and palatoclosis. So you can see the intrinsic muscles, which are longitudinal. These are the transverse group of muscles, vertical group of muscles, and extrinsic muscles, they are the palatoclosis. Okay, one which is going from palate to the tongue, genioglossus from the mandible to the tongue, hyoglossus from the hyoid to the tongue, styloglossus from the styloglossus to the tongue. These are the extrinsic muscles of the tongue, and the others are parintrinsic muscles. So there is a superior longitudinal muscle, which lies just beneath the mucosal membrane, and it shortens the tongue and makes the dorsum of the tongue concave. So this is a layer. Superior longitudinal, this is an inferior longitudinal. So inferior longitudinal muscle, it lies close to the inferior surface of the tongue between genioglossus and hyoglossus, and it shortens the tongue and makes the dorsum of the tongue convex. So these are the muscles. The superior is to make the tongue concave, and this muscle, inferior longitudinal, is useful to make the tongue convex. And there are the transverse muscles which extend from the median septum to the margins and makes the tongue narrow and elongated. So these are the transverse group of muscles. And then the vertical muscles, they are found at the borders of the anterior part of the tongue and makes the tongue broad and flattened. These are the vertical group of muscles which make the tongue broad and flat. And coming to the extrinsic muscles, the genioglossus, hyoglossus, styloglossus, and palatoclosis. So the genioglossus, it originates from the upper genital tubercle of mandible, hence the name the geniome. And it is inserted into the upper fiber. Upper fibers are inserted to the tip of the tongue, the middle fibers to the dorsum of the tongue, and the lower fibers to the hyoid bone. And they retract the tip and depress the tongue and pull the posterior part forwards. That is, they help in the protrusion of the tongue. So these are the genioglossus muscles. Okay, some part into the tip of the tongue, some into the middle part, some into the hyoid bone. Upper, middle, and lower fibers. Then hyoglossus muscle. It originates from the greater cornua and lateral body of hyoid, and it is inserted into the side of the tongue. It is helpful in depressing the tongue, retracting and protruding the tongue. So these are the hyoglossus muscles. And styloglossus, they arise from the tip and anterior part of the styloid process, and they are inserted to the side of the tongue, and they pull the tongue upwards and backwards during swallowing. Palatoclosis, they arise from the oral surface of palatine aponeurosis, and they are inserted into the side of the tongue or the junction of oral and pharyngeal part of the tongue. So this muscle helps in pulling up the root of the tongue and approximates the palatoglossal arches. So this is a styloglossus muscle, and this is a palatoglossous muscle. The same thing. So this is a genioglossus, and this is a styloglossus, stylohyoid, palatoglossus. This is a styloglossus. There is a tongue with a frenulum, which is the inferior extension of the tongue. There is also the same extrinsic muscles which are shown. So this is one more view showing the intrinsic and extrinsic muscles. So you can see this is a vertical and transverse group of muscles. These are superior longitudinal group. These are inferior longitudinal group. These all are paired muscle groups. These are the intrinsic muscles of the tongue. Then coming to this is a median septum. Extrinsic muscles are the genioglossus, hyoglossus, styloglossus. Here is a styloglossus muscle. Yes, palatoglossus, we cannot appreciate in this picture. So there is a midline fibrous septum which attaches to the hyoid bone posteriorly, and it is present through the entire tongue and does not reach the dorsum of the tongue. It provides an avascular plane. So this is a midline or median fibrous septum. Coming to the arterial supply of the tongue, There are paralingual arteries, which are branches from the external carotid artery. They run above the greater horn of the hyoid bone, deep to the hyoglossus muscle, and they pass towards the tip of the tongue. And beneath the hyoglossus, there are dorsal lingual branches which go into the posterior part. At the anterior border of hyoglossus, they branch to the sublingual gland and the floor of the mouth and continue as deep lingual arteries. So here is this is a external carotid artery, which is giving a lingual artery, and which runs in relation to the hyoglossus muscle and gives the dorsal lingual arteries. And here it gives branches to the sublingual gland and also to the tongue as a deep lingual artery. It continues as a deep lingual artery. Okay. The same picture, where it's showing the lingual artery, and this is a deep lingual artery. The branches to this is sublingual branches, and these are the dorsal lingual arteries. Venous drainage. Venous drainage accompanies the lingual artery. There are dorsal branches which drain the dorsal lingual vein, and from the tip they drain into the deep lingual vein, and this vein runs back superficial to the hyoglossus and joins the sublingual vein from the sublingual gland to form the vena commitans of hypoglossal nerve. It continues backwards close to the nerve and joins either the lingual vein or facial vein or internal jugular vein. The lingual vein usually joins IJV near the greater horn of hyoid bone. So here you can see this is the lingual veins, the dorsal lingual vein and deep lingual vein. This is these run along the lingual vessels, lingual artery. Okay, this is a dorsal lingual vein, and this is a deep lingual vein in relation to the hyoglossus muscle. They combine, and they this is a common carotid artery. They combine, and finally they drain into the internal jugular vein. And nerve supply. All the muscles of the tongue are supplied by the hypoglossal nerve, except palatoglossus, which is supplied by the pharyngeal plexus. This is a motor supply. Coming to the sensory supply, the anterior 2/3 of the tongue is the general sensation is supplied by the lingual nerve, which is a branch of trigeminal nerve, and taste by cauda tympani nerve. Posterior 1/3 of the tongue, glossopharyngeal nerve gives both general sensation and special sensory, that is taste. The posterior most part of the tongue is supplied by the vagus nerve to the internal laryngeal branches. Parasympathetic secretomotor fibers to the anterior lingual gland, superior salivary nucleus is supplied via the superior salivary nucleus, cauda tympani nerve, and rely in the submandibular ganglion. Okay, this is a picture which is showing the specified nerve supply. You can see the anterior 2/3 and posterior 1/3. Here it is supplied by the lingual nerve and cauda tympani nerve, and the muscle supply is by hypoglossal nerve. Palatoglossus is supplied by vagus nerve or the pharyngeal plexus, and the special sensations on the posterior 1/3 is by glossopharyngeal nerve, and the pharyngeal part by internal laryngeal nerve. So during surgery of the tongue, that is glossectomy, a preservation of at least one hypoglossal nerve is needed in order to maintain mobility and oral function. Referred otolgia in cancer tongue is because of trigeminal nerve stimulation, which also has a sensory branch to the external auditory canal and tympanic membrane and temporomandibular joint via the auriculotemporal nerve. And glossopharyngeal nerve is sensitive to the middle ear, and it is called Jacobson's nerve. So there is a referred pain in CA tongue patients because of these two nerves, that is the trigeminal nerve branches and glossopharyngeal nerve branches. So this is the hypoglossal nerve which supplies all the muscles of the tongue except palatoglossal muscle, and you can see the protruded tongue is uh, deviated towards the side of the lesion due to the unopposed action of the genioglossus muscle. Okay, this is a genioglossus muscle which protrudes the tongue. Since the opposite side, the genioglossus is lost, because of high action of the normal nerve, the tip of the tongue is deviated towards the side of the lesion. So the genioglossus on the side of the lesion is paralyzed because of damage to the hypoglossal nerve, either by involvement due to involvement by the growing tumor. Lymphatic supply of the tongue. So the tip of the tongue generally drains into the submental group of lymph nodes, which are level 1A. The lateral tongue into the submandibular nodes, which are level 1B, and jugulo-digastric nodes, that is level 2, and jugulo-omohyoid nodes, which are level 3. The base of the tongue is supplied by jugulo-omohyoid and jugulo-digastric. The base of the tongue is drained into jugulo-omohyoid and jugulo-digastric nodes, and there is a communication of lymphatics across the midline, and there is a high incidence of bilateral metastasis. So this is the lymphatic drainage. You can see the posterior part is going into the superior deep cervical nodes, and there is a crisscrossing of lymphatic supply. That is, there is no strict ipsilateral lymphatic drainage. Lymphatics from either side will drain into both sides of the neck. Okay, so from the posterior part, midline, posterior mid part of the tongue to the inferior deep cervical nodes, and the lateral part to the submandibular tip to the submental nodes. The same picture. So levels of nodes, cervical nodes 1, 2, 3 carry highest risk of metastasis from oral squamous cell cancer. Metastasis to level 4 and 5 are very rare. So in order to know the metastasis to the neck, we need to discuss about the lymph nodes of the neck. So lymph nodes of the neck are divided into 7 groups. 1A is the submental nodes, 1B is submandibular, 2A and 2B are upper jugular, 3 is middle jugular, 4 is lower jugular, 5A and B are the posterior triangle group, level 6 is anterior compartment group, and level 7 is superior mediastinal group. So this is the submandibular, upper jugular, omohyoid. Level 4 is lower cervical. This is posterior triangle, anterior compartment, and 7 is superior mediastinal. So level 1, they are bounded by the body of the mandible, anterior belly of contralateral digastric, posterior belly of ipsilateral digastric, and stylohyoid muscle. This is a level of level 1A nodes. So level 1A is by anterior belly of digastric muscle and hyoid bone. Between the two digastric muscles and the hyoid bone, this is level 1A. And it is involved in the pathology of the floor of the mouth and anterior oral cavity, anterior mandibular alveolar bridge, and lower lip. Submandibular level 1B. It is bounded by anterior belly of digastric, stylohyoid, posterior belly of digastric, and body of mandible. So these are the region of level 1B. It is involved in the pathology of oral cavity, anterior nasal cavity, soft tissue structures of midface, and submandibular gland. Many of these lymph nodes lie in close proximity to the submandibular gland, and it is removed to ensure that the excentration of all lymph nodes within this triangle. There are peripheral lymph nodes which drain the lip, buccal mucosa, nasal cavity, soft tissue of neck, sometimes get involved along with level 1 groups. Nodal dissections performed for nodal disease associated with primary lesions of these sites should be modified to encompass perifacial nodes. The level 2 nodes, they are the upper jugular nodes, which contain two groups, that is level 2A and 2B. They are located around the upper third of internal jugular vein and adjacent spinal accessory nerve. They extend superiorly. The extent is from skull base inferior to the inferior border of hyoid bone. Anterior-medially, there is a styloid muscle. Posterior laterally, it is a posterior border of sternocleidomastoid. So this is the level 2 region. So level 2A nodes are located anterior to the vertical plane defined by the spinal accessory nerve. Level 2B are located posterior to the vertical plane defined by spinal accessory nerve. So this is roughly the spinal accessory nerve, which is dividing the 2A and 2B. So they are involved in the pathology of oral cavity, nasal cavity, nasopharynx, oropharynx, hypopharynx, larynx, and parotid. Level 3 nodes are the middle jugular lymph nodes. They are located around the middle third of the internal jugular vein. They extend superiorly the carotid bifurcation, inferior aspect of hyoid bone. And inferior is the junction of omohyoid muscle to the internal jugular vein or the lower border of cricoid arch of cartilage. Medially, it is a lateral border of sternohyoid muscle, laterally the posterior border of sternocleidomastoid. So this is posterior border, and here will be the upper division of common carotid, and it is cricoid margin. So level 3 nodes are involved in oral cavity, nasocavity, oropharynx, hypopharynx, and laryngeal pathology. Level 4 nodes are the lower jugular group of lymph nodes located around the lower one-third of internal jugular vein, and they extend superiorly from the junction of omohyoid muscle with IJV or lower border of cricoid cartilage arch. And inferiorly, there is a clavicle. Medially, it is bounded by the anterior border of sternohyoid, and laterally by the posterior border of sternocleidomastoid. So this is the level 4 group of lymph nodes. That's the level 4 group of lymph nodes. So level 4 are involved in hypopharyngeal, thyroid, cervical, esophageal, and laryngeal pathology. Level 5 are the posterior triangle lymph node groups. They are located along the lower half of the spinal accessory nerve and transverse cervical artery. They extend superiorly the convergence of sternocleidomastoid and trapezius muscle, inferiorly the clavicle, medially the posterior border of sternocleidomastoid muscle, and laterally the anterior border of trapezius muscle. So this is the sternocleidomastoid, this is the trapezius, and the triangle contains level 5 nodes, 5A and 5B. So 5A is separated from 5B by a horizontal plane. So level 5A is separated from 5B by a horizontal plane, marking the inferior border of anterior cricoid arch. Level 5A are the spinal accessory nodes, and level 5B are nodes following the transverse cervical vessels and supraclavicular nodes, and not Virchow nodes. Virchow nodes are located at level 4, level 5 are not Virchow nodes. So these are involved in the pathology of nasopharynx, oropharynx, cutaneous structures of scalp, posterior scalp, and neck. And level 6, they are the lymph nodes of the anterior compartment of the neck. They surround the midline visceral structures of the neck. They extend superiorly. The extent is superiorly the hyoid bone, inferiorly is a suprasternal notch, laterally the medial border of carotid sheath on each side. So lymph node groups are pretracheal, paratracheal, precricoid, perithyroidal, and nodes along the recurrent pharyngeal nerve. So it is involved in the pathology of thyroid gland, glottis, subglottis, larynx, apex of piriform sinus, and cervical esophagus. Level 7 nodes. They are the superior mediastinal group of nodes. extension of paratracheal group extending inferiorly below the suprasternal notch along each side of cervical trachea to the level of innominate artery. So they extend the superiorly there is a superior extent the superior edge of mandible, inferiorly the inferior border of arch of aorta. Laterally it is a common carotid artery on the left side, right side it is the innominate artery. So this is a level 6 anterior compartment, and somewhere here is a level 7. So coming to the carcinoma trunk. So carcinoma tongue incidence. Oral cancer is 6th most common cancer. In India, tongue cancer is among the top 8 common cancers. So carcinoma tongue is the second most common site of oral cancer after lip. So the common age of presentation is elderly patients with in 5th or 6th decade, men with a higher frequency in men when compared to women. So site-wise incidence, the middle 1/3 of lateral border of the tongue is a commonest site occurring in about 47% of cases, and posterior 1/3 lesions occur in 20% of cases. Tip of the tongue lesions occur in 15% of cases, and ventral surface and frenulum in 9%, and dorsum of the tongue in 6.5%, and facial lingual involvement in 6% of cases. So, etiology of tongue cancer, it is mostly the tobacco, smoking, and chewing in any form. Smokers have a 1.9-fold risk of cancer in males and 3-fold risk of cancer formation in females. So, the risk increases with the number of years of smoking and number of smoked cigarettes per day. So 90% of the patients with tongue cancer have a history of tobacco use. It takes 20 years for a smoker or a tobacco chewer to abstain from about to clear of the risk of developing cancer. So tobacco chewing increases the risk 8 times for buccal cancer. With quid, the risk increases to 10 times. If the quid is kept overnight in the mouth, the risk increases to 30 times. Reverse smoking with a fire inside the mouth is also a very known risk factor for CA. In a study by Moore, 40% of patients who persisted smoking after the cure of primary oral cancer developed a second cancer when compared to 6% of those who quit smoking. So alcohol consumption alone or combined with smoking is a risk factor for development of CA tongue. So there is 1.7-fold risk of developing cancer in males who have 2 drinks per day, and 3-fold risk in heavy drinkers. Patients who smoke 2 packs per day and drink 4 units of alcohol have 35-fold increased risk of development of oral carcinoma. So whenever we are advising patients, we have to advise them to quit smoking and alcohol as a preventive step to decrease the incidence of oral cancer. And chewing beetle, quid, pan, areca nut, HPV virus infection 16 are some of the other etiological factors for CA tongue. And HPV is detected in about 60 to 90% cases of oral cancer, and it is present in 40% of normal oral cavity. And HIV, AIDS, and immunosuppression are also etiological causes for development of oral cancer, and along with Epstein-Barr virus. Dietary factors which lead to oral cancers are iron deficiency anemia, and which are protective are vitamin A, fresh fruits and vegetables. Iron deficiency anemia may lead to squamous cell carcinoma of hypopharynx and oral cavity. Other conditions like poor dental hygiene, ill-fitting dentures causing chronic irritation, upper digestive tract cancers are some of the other etiological factors for development of CA tongue. So this is an important slide which shows the pre-malignant conditions of oral cavity. So the pre-malignant or precancerous lesions include leukoplakia, erythroplakia, and chronic hyperplastic candidiasis, which is these are divided into low risk and high risk conditions, and intermediate risk and doubtful association. So this oral submucosal fibrosis, syphilitic bursitis, hydropenic dysphagia are other big pre-cancerous conditions, and doubtful association is associated with oral lichen planus, discoid lupus erythematous, and disc keratosis congenita. So describing each, leukoplakia is a white patch or a plaque that cannot be characterized clinically or pathologically as any other disease. So clinically, it is present as a white or gray, soft or crusty lesion. It may persist the same since occurrence, or it may regress, it may progress, or it may recur after excision. So there are two types of leukoplakia, which is called nodular leukoplakia, homogeneous leukoplakia. Speckled or nodular leukoplakia is more common to turn into malignancy. Pathological changes in leukoplakia include hyperkeratosis, parakeratosis, acanthosis. So there is an overall 5% risk of malignant transformation of leukoplakias. Over 10-year duration, there is a risk of 2.4%, and over 20-year duration, there is a risk of 4%. For age less than 50 years, the instance of malignancy is 1% in patients with leukoplakia. Between 70 to 89 years, it is 7.5%. Leukoplakia of the floor of the mouth and ventral surface of the tongue. There is high incidence of malignant change due to the pooling of carcinogens in the floor of the mouth. So this is a classical picture, which here you can see a white patch in the lateral surface of the tongue. Most cases of leukoplakia will disappear if alcohol and tobacco consumption ceases. 1 year cessation, leukoplakia will disappear in 60% of cases. Biopsy from suspicious areas, ulceration, induration, and hyperemia is done. Biopsy from suspicious areas is done when there is ulceration, induration, and hyperemia. Surgical excision or CO2 laser can also be used, and they have to be regularly followed up at 4 months interval. Erythroplakia is a lesion of the oral mucosa that presents as a bright red velvety plaques which cannot be characterized clinically or pathologically as any other recognizable condition. So incidence of malignant transformation is 17 times higher than leukoplakia, and it occurs mostly about the age of 60 years, and it must be excised surgically. So this is a red patch you can see, which is and chronic hyperplastic candidiasis. It is also a pre-malignant condition. There are dense chalky plaques of keratin deposits, which are more opaque than non-candidial leukoplakia. These are mostly seen in the commissures of the oral cavity, and there is a candidial infection with an immunological defect, and there is high incidence of malignant change. Then oral submucosal fibrosis. There are fibrous bands beneath the oral mucosa which progressively contract and ultimately result in restriction of mouth opening and tongue movements. So there is a slow growing squamous cell carcinoma is seen in about 1/3 of the patients. So you can see that there is a submucosal fibrosis. There are the bands just beneath the mucosa. So it is strongly associated with chewing ericanet. It is a pre-malignant condition. It can affect any part of the oral mucosa. There are palpable fibrous bands over the oral mucosa and retromolar area and rima oris. And restriction of mouth opening and presence of trismus is a common presentation. It will not regress with the cessation of ericanet chewing. Syphilitis glossitis. It is one of the pre-malignant conditions. Which leads to endarteritis, atrophy of the overlying epithelium, this epithelium becomes more vulnerable to irritants, leading to the development of squamous cell cancer, even in the absence of leukoplakia. And these changes are irreversible. This is one syphilitic glossitis picture. Then coming to the pathology, Squamous cell cancer occurs in about 95% of oral malignancies. Other glands, other sites as malignant salivary gland lesions, mucosal melanomas, lymphomas, and sarcomas also occur in also come under oral cavity cancers. And in the earliest recognizable stage, squamous cell cancer, there are presence of firm pearly plaques or irregular roughened verrucous areas of mucosal thickening. Pathological types of tongue squamous cell cancer include ulcerative, warty, indurated, and fissures types. So ulcerative is the most common and with irregular everted edges and indurated bases. Warty growths usually occur over previous leukoplakias. Indurated masses or plaques occur anywhere over the tongue, and fissures usually follow the superficial glossitis. Okay, this is one ulceration you can see on the lateral surface of the tongue. Mode of the spread. So, CA tongue usually has a local spread, infiltration, and invasion. And anterior 2/3 of the tongue, they spread to the floor of the mouth and crosses midline. Sorry. In posterior 1/3 of the tongue, they spread to the tonsil, pharynx, soft palate, and epiglottis. So mandible infiltration. So mandible, which is a very close proximity to the tongue. So there is high chance of mandible infiltration. So oral cancers have got both radial and vertical growth. And the cancer spreads along the floor of the mouth and reaches the mucoperiosteum of the mandible. There is a dentate or edentulous mandible may be present, or previously radiation may be taken, may not be taken. So when it reaches the mandible, the mucoperiosteum is relatively resistant. So once there is no dentition after tooth extraction, this mucoperiosteum is disrupted. So when there is dentition, teeth are attached to the alveolus by periodontal ligaments. After tooth extraction, there is a hematoma in alveolar pockets which epithelize, and there is pore resistant to inflation. That is, there is the mucoperiosteal layer is slightly interrupted. And in edentulous mandible, there is bone resorption and reduction in the height of mandible and pore resistance to infiltration. So such cases, there is high chances of tumor infiltration to the mandible. So the cancer spreads along the mucoperiosteum. It destroys the periodontal ligaments and gains access to the alveolus. And then the tumor travels along the root of the tooth and reaches the spongy bone of the mandible. And they spread along the spongy neurovascular bundle of the mandible and involves the inferior alveolar canal. So they extend along the perineural space of alveolar nerve, the mandibular nerve, and cavernous sinus. So this is the space, the spongy bone. So when this spongy bone is involved, it will have the nerve involvement, and patient has symptoms based on nerve involvement, and the bone also gets weakened. So distance spread, that is about local spread. Distance spread is through to the lymphatics or the lymph nodes of the neck. Tumors of the oral cavity and floor of the mouth have high propensity to metastasize to the neck lymph nodes when compared to any other oral cancers. So generally, patients present with a non-healing painless ulcer, excessive salivation because of irritation caused by the ulcer, pain, which is a very late feature, mostly occurs due to the involvement of nerves, and there is a deferred pain because of common innervation by glossopharyngeal and trigeminal nerves, and pain on swallowing in the posterior 1/3 tumors. So this is a classical ulcer. On the lateral 1/3 of the tongue, you can see there is a lot of excess salivation. And there is restricted movement of the tongue. Patient complains of difficulty in pronouncing certain words. And there is infiltration of the muscles of the floor of the mouth, causing ankyloglossia. That is, a tongue doesn't move properly. And there may be bleeding, there may be a bad odor, and trismus due to involvement of pterygoid muscle. And there may be mandibular involvement because of bone infiltration and alveolar nerve involvement. So how are we going to evaluate? We have to take a history about the personal habits, hygiene, family history, tobacco chewing, smoking, alcoholism, tooth extraction, failure of the socket to heal, unexplained tooth mobility, and difficulty in wearing dentures. and history of difficulty in opening the mouth, protrusion of the tongue, difficulty in swallowing, salivation, talking, history of earache. And upon physical examination, we are going to observe for slurring of the speech when the tongue muscles are involved. And oral cavity, we have to look for the for ankylosing, that is inability to protrude the tongue or fixation of the tongue because of involvement of muscles of the tongue, and ulcers that bleed to touch. We have to look for profuse salivation, which is due to the irritation of the nerve fibers of the taste and results in difficulty, and also as a result of difficulty in swallowing. We have to look for the deviation of the tongue, which involves involvement of hypoglossal nerve. To look for induration of the tongue when the tongue was inside the mouth. And we have to palpate the back of the tongue. The tumors of the posterior third of the tongue will spread to the tonsil and pillars. We have to examine the cheek, gum, floor of the mouth, trigon, areas of retromolar areas and tonsillar areas for the presence of a second primary tumor. And infiltration of the mandible causes pain and swelling of the jaw. So you have to examine for the mandible also. And we have to look for the cervical nodes. And carcinoma tongue is a systemic disease. Therefore, look for metastasis, especially the lung metastasis. And we have to look for the precancerous lesions, a complete head and neck examination, indirect laryngoscopy, dental and mandibular evaluation should be done. And OPG, which is a X-ray of the mandible, should be taken. CT scan is indicated when you are suspecting involvement of pterygoid muscles and patients with trismus and lesions which are affecting the mandible, where in cases where we are planning for a marginal mandibulectomy in order to clinically evaluate negative necks, and then also patients with large nodes to look for carotid artery involvement. It is also useful to assess assessment of pterygoid muscles. So this is an orthopantogram. You can see the involvement of mandible. There are loss of tooth on this left side, and there is weakening of bone. And this is a fracture line, I think. So MRI is an investigation of choice to assess infiltration and to detect the perineural spread of the tumor. It is useful for the tongue for assessing the extent of cancer. It is also useful for oral and oropharyngeal cancers. Its advantages over CT is that image is not degraded by the presence of a metallic dental restoration. So whenever there is a metallic denture, so it is picture quality is not degraded in MRI. So PET-CT also evaluates, can also be done, which evaluates the response to chemotherapy in primary and nodal stage sites and with unknown primary and distant mets. So ultrasound of the neck is useful for ultrasound guided aspiration of the nodes and for surveillance of the patients, and also for detection of any other secondary growths after N0 neck management. So X-ray we can do for facial bones, and wedge biopsy of the primary lesion can be done in case of suspicious cases, and FNAC of the lymph nodes can be done. So we have to do indirect and laryngoscopy, pharyngoscopy, esophagoscopy to rule out the presence of second primary and to completely assess the extent of tumor. So TNM staging, it is TX, T0, carcinoma in situ. T1 is tumor less than 2 centimeters. T2 is tumor 2 to 4 centimeters. T3 is tumor more than 4 centimeters. T4 is invasion of cortical bone, extrinsic muscles, maxillary sinus, and skin of the face. T4B is invasion of pterygoid palate, pterygoid plate, skin of skull base, and ICA, that is internal carotid artery. Nodes, again, the N1 nodes are ipsilateral single less than 3 centimeters. N2 is ipsilateral node, which is 3 to 6 centimeters. N2B is multiple ipsilateral nodes. N2C is bilateral or contralateral nodes less than 6 centimeters. And N3 nodes are more than 6 centimeter nodes. Midline nodes are considered as ipsilateral nodes. So metastasis, no distance metastasis, and metastasis. So this is staging. So involvement of nodes is stage 3. N1 nodes is stage 3, N2 nodes or NET is stage 4A, and N3 nodes are 4B, and metastasis is 4C. So treatment depends on the site of the tumor, presence of previous radiation, history, and personal status, stage of the tumor. Early stage, we have to go for surgery. Intermediate stage, surgery plus radiotherapy. Late stage also, we can go for surgery plus radiotherapy. So what is the aim of our surgery? So aim is complete excision with microscopically clear margins, nodal management, reconstruction of tissue loss, restoration of function, and improved quality of life. So the treatment options for early stage T1, T2, N0 disease, surgery plus radiotherapy. You can go for external beam radiotherapy or brachytherapy. T3, N0, T4, N0, and all other node positive diseases other than N3. You can go for surgery plus postoperative radiotherapy added with or without chemotherapy. T4B disease, that is the stage 3 disease with N3 and with metastasis in stage 3 and 4. So you can go for a palliation radiotherapy plus chemotherapy. So primary tumor treatment T1 and T2, you can go for a single modality surgery or radiation. T3, T4, you have to go for a combined modality, chemoradiation or surgery and post-op party. Next treatment N0, N1 nodes, you can go for surgery or radiation. N2, N3 nodes, you can go for surgery with post-op chemoradiotherapy. Both sides of the neck are treated when there are midline lesions. So this is already discussed. High risk of local regional recurrence is present with single modality treatment. T1 and 0 when it is superficial, less than 4 mm size of the tumor, and which is well differentiated, you can go for surgical resection or radiotherapy. T1 and 0 more than 3 millimeters, and T2 and 0 have high propensity for nodal metastasis. So whenever there are no nodes, but only no palpable nodes, and only the tumor is present, so you have to manage the neck nodes also. So there is high instance of occult metastasis in N0 neck with instance of 15 to 43%. So you have to do the surgery for the primary, and you have to go for neck dissection. Brachytherapy for primary can be done, and EBRT for neck can be done, or elective neck dissection can also be done. For locally advanced tumor, combined therapies can be done. T1, T2, and N1, N2, that is stage 3 and 4A. Surgery, which is the wide excision of the primary tumor, and neck dissection can be done. Or radiotherapy, which includes EBRT or brachytherapy for primary, followed by EBRT for neck. So surgical salvage for primary or neck is reserved for clinical or radiological residue. So whenever there is a surgery failure, you can go for a radiotherapy, but post radiotherapy, you cannot go for surgery. So midline nodes, both sides, we have to go for neck dissection. Adjuvant radiotherapy following neck dissection can be given when the node size is larger than 3 centimeters, history of multiple metastatic deposits, and node shows extracapsular invasions. So T3, T4A into disease, that is a 4A. If it is in the anterior tongue, if it is resectable, you go for surgery and add it with chemotherapy. If it is or if it is not resectable, you can go for primary chemotherapy and surgical salvage. You can go for so primary chemotherapy may totally regress the tumor, which is called a complete response. Okay, then T4B and 3, that is a stage 4B disease, you better go for a chemoradiation therapy. If after therapy, if it is resectable, you can go for a surgery. So stage 4A, 4B, you have to go for local regional therapy plus chemotherapy. Chemotherapy is given by paclitaxel, docetaxel, platinum compounds. And when there is a very large primary tumor or node, you have to go for chemotherapy initially for downstream. So complete response after chemo or radiotherapy occurs only in 5 to 10% of cases. Such cases, you can go for a follow-up. Post-radiotherapy recurrent tumors, second primaries occur in the field of radiation. So such cases, you have to go for surgery. So it is called surgical salvage of radiotherapy failure. So radiation selective situations where disease-free survival is long can be considered. So criteria for unresectability. So whenever you are having a tumor, so you have to know whether it is resectable or not. So criteria for unresectability includes involvement of skull base, extensive skull base involvement, extensive perineural involvement, carotid artery infiltration, encasement of the primary tumor, carotid artery encasement for the primary tumor or lymph node, and extensive soft tissue involvement, extensive cutaneous lymphedema and nodules. So what will you do when the tumor is in the posterior third of the tongue? So posterior tongue tumors, surgical resections may not be feasible sometimes and will be of unacceptable morbidity. So we go for a primary chemo radiation. And post-radiation residual cancers, we can go for a surgical resection. Plus bulky flaps may be needed to reduce aspiration and during deglutition and for reconstruction. And radiotherapy, which radiotherapy can be given in early stages. It has got equal efficacy as surgery when given in early stages. It is either brachytherapy, teleradiotherapy, external beam radiotherapy, combined therapy. Post-operative radiotherapy is preferred over pre-operative radiotherapy. So primary radiotherapy, radiation is given as a primary treatment. So what is the advantages? The radiotherapy kills the oxygenated cells, or so a radiation in a initial tumor. Primary radiotherapy radiation on a well oxygenated tumor cell. So it is unhampered by post surgery fibrosis. So there is higher response we can expect. And centripetal contraction, there is scope of improving the surgical margin. The size of the tumor shrinks. RT failures, tumor cells in the center of the field. So when the tumor cells are in the center, the margins of the tumor become inactive, but the tumor in the center of the field may be active. While post-surgery failures, the margins of the tumors may regrow. So post-surgical radiation must include entire surgical margin, incision, draining sites, and needs larger fields, hence more morbidity. So disadvantages are endarteritis, wound healing problems if surgery is being performed later. It can be reduced by vascularized tissue flaps for reconstruction. So whenever it is given preoperative, when is it given preoperative? In case of inoperable cases, for downsizing the tumor and for patients who are unfit for surgery. Postoperative T3, T4 primary tumor, positive surgical margins, that is after surgery, if the margins are positive, we can go for a radiotherapy. Presence of perineural, perivascular, lymphatic invasions, and presence of macroscopic cross residual disease, you can go for a postoperative radiotherapy. Extracorpuscular spread, pathologically positive nodes. So this is the dose of EBRT, 6,500 to 7,000 rads, and brachytherapy. You can give larger doses. Iridium, silicium needles can be placed in the tumor, and up to 1,000 rads can be delivered to small area. Effects of radiotherapy: xerostomia, erythema, skin ulceration, dental sloughing, caries, osteoradionecrosis, wound healing problems. So surgery for the primary tumor includes transoral approach, transmandibular approach, transpharyngeal approach. So transoral approach is for small anterior tongue cancers that can be adequately exposed, removed, and reconstructed without any additional incisions. Superficial tumors in situ, 2 cm cuff of normal tissue. For defects 3 to 4 centimeters, we can do a primary closure with 30 chromic or vital sutures in 1 or 2 layers, and for lateral tongue defects, and 2 layers for midline tip defects. If defect is large, the tongue is folded back to close the defect. For defects involving half of the anterior tongue, a nasolabial or a free radial forearm flap may be needed to reconstruct. Defects more than half of the tongue, calcaire flaps are needed to restore the volume to aid in speech and swallowing. So lip splitting or cheek flap transmandibular approach is the lip splitting cheek incision is combined with the lateral mandibulotomy, and it gives an excellent exposure to large anterior tongue and base of the tongues, and it is done along with neck dissection. So here total glossectomy can be done and reconstruction using large bulkier flaps to prevent aspiration and preservation of larynx. And frequently after this, prolonged or permanent gastrostomy and tube feeding may be required in some patients. Recurrent aspirations may occur, so total laryngectomy may be indicated in some patients. Then lateral pharyngotomy approach, it is for small tumors at the base of the tongue, and it avoids injury to the hypoglossal superior laryngeal nerves. Complications of surgery are rarely related. Wound healing problems may be there, fistula formations, oronasal, oropharyngeal fistulas, which are very bad in healing, and mandibular necrosis, hemorrhage, carotid blowout problems, and degradation issues and speech-related issues may be present. Airway-related obstruction may be because of edema, hematoma, seroma formation, nerve injury. So you can deal them with tracheostomy. Hemorrhage may be because of carotid blowout, which may be an emergency. So it requires a carotid artery ligation, and oral and pharyngeal dysfunction causes dysphagia aspiration. So you have to go for a nasogastric tube feeding or a gastrostomy feeds. Orocutaneous or pharyngocutaneous fistulas lead to malnutrition. Fistulae may occur post malnutrition, radiation, mucosal closure under tension, infection, foreign body, residual tumor. So initially you can go for a wide drainage or wound packing and compressing these things. If there's if the fistula is persistent, you can go for a re-exploration of the wound and closure of the fistula with vascular flaps. So mandibular complications include osteotomies, poor wound healing, osteoretal necrosis of the mandible, malocclusion, malunion, and you can do a mandibular fixation. Effects. Lateral mandibular resection, you can go for jaw occlusion exercises and segmental resections, and flap related complications include flap loss. The treatment of the neck, radical neck section involves removal of all 5 lymph nodes, 5 levels with spinal accessory nerve, internal jugular vein, and square and sternocleidomastoid muscle. Modified radical neck dissections includes all 5 levels with preservation of all the 3 structures. Type 1 MRND includes preservation of spinal accessory nerve. Type 2 includes spinal accessory plus IJV preservation. Type 3 includes preservation of spinal accessory nerve, internal jugular vein, and sternocleidomastoid muscle. All 3 structures are preserved. So any zero neck, when there are no nodes palpable, we can go for a supraomohyoid dissection, which includes the levels 1 to 3. If the nodes have any tumor invasion, you can go for a radiotherapy. Extended omohyoid dissection includes level 4. So pathologically positive nodes, you can go for a radical neck or modified radical neck dissection. So these are the chemotherapy regimens, which includes cisplatin for 6 to 7 weeks, or cisplatin added with paclitaxel, cisplatin added with 5-FU, and given for 4 weeks, and cisplatin alone with concurrent radiotherapy. So palliative care includes chemoradiotherapy. Palliation is for pain, fungating masses to relieve airway obstruction in case of very late stage disease, advanced stage disease where surgery cannot be done. Tracheostomy for stridor, feeding tubes like PEG and nasogastric tube gastrostomy, and jejunostomy tubes for feeding, and external carotid artery ligation in order to prevent life-threatening tumor bleeding. So follow-up we can do for first year follow-up is for every 1 to 3 months. Second year follow-up every 2 to 4 months. Third year follow-up for 3 to 6 months. Fourth and fifth year every 6 months, and after 5th year every 1 year. So poor prognosis occurs when the tumor thickness is more than 4 mm and poorly differentiated tumor with high grade and perineural vascular and lymphatic invasion, DNA polypoid status such as aneuploidy and varicose cancer. So survival for stage 1 disease is 70%, and for stage 2 is 40%. For stage 3 is 25% for stage 4 is less than 20%. So overall survival is around 50%. Thank you.